In this session, we are going to have a look into genetic screening in breast cancer. Genetic screening is becoming more affordable and available to a lot more people, and as a result, radiologists being one of the frontliners in seeing these patients, we should have a fair idea of whom we should be referring for genetic screening. 1 in 8 to 12 women develop breast cancer in their lifetime. The National Comprehensive Cancer Network has put out certain guidelines on who needs to be referred for genetic counseling. A patient with his personal history of breast cancer, diagnosis less than 50 years of age, a triple negative breast cancer diagnosed at less than 60 years of age, personal history of 2 breast cancer diagnoses regardless of age of onset, known mutation in a cancer susceptibility gene within the family, multiple close family members with related cancers like breast, ovarian, colon, endometrial, prostate or pancreatic, diagnosis of ovarian cancer, diagnosis of breast cancer in men, Ashkenazi Jewish descent with personal history of breast, ovarian or pancreatic cancer. The genes are classified into 2 high-risk genes and moderate-risk genes. The high-risk genes and the ones which we are commonly familiar with are the BRCA1 and BRCA2. The other high-risk genes are TP53, PTEN, CDH1, STK11. Moderate-risk genes include ATM, CHEK2, PALB2. BRCA1 and BRCA2 are responsible for 6% of the breast cancers. BRCA1 gene is located on chromosome 17, while BRCA2 gene is located on chromosome 13. In these breast cancers, the age of presentation is around 40 years, unlike the normal sporadic, which comes around 60 years. By 70 years, 60% of BRCA1 mutation patients will develop cancer. BRCA2, 45%. Mammogram sensitivity drops to 30% in these cancers. Normally, mammogram has a sensitivity of 83% in sporadic breast cancer. The reason being the dense breast and the difficulty in detecting cancer. BRCA1 is associated with the higher grade. It tends to be hormone receptor negative and is of a larger size and hence a poorer prognosis. Majority of the breast cancers are invasive ductal carcinoma. Only 8% of these gene-related cancer is invasive lobular carcinoma. A subset of the BRCA1 cancer, the medullary type, may present with a benign imaging morphology. Around 20% of BRCA1 cancers are of this subtype. BRCA2 cancer presents similar to the sporadic cancer. Ductal carcinoma in situ is common. It is estrogen receptor positive, and mammogram will show calcification in these cases. Male breast cancer, BRCA2 has an increased lifetime cancer risk. Average age of detection is 60 years. BRCA1 and BRCA2 have associated cancers involving ovaries, peritoneum, fallopian tubes, pancreas, prostate, and colon. Ovarian is more common in BRCA1. Prostate malignancy is associated with BRCA2 and tends to be aggressive. So how do we screen these patients? From 25 to 29 years, an annual breast MRI is recommended. 30 to 75 years, both an annual mammogram and an MRI. For men, annual screening with clinical exam from 35 years. Prostate cancer screening from 45 years for BRCA2. 40 to 50 years, a screening colonoscopy has to be done every 3 to 5 years, especially in BRCA1. A 50% reduction in breast cancer is possible if a risk-reducing salpingo-oophorectomy is done before menopause. Those patients who are not willing for a surgery, an annual screening, pelvic ultrasound, and CA125 screening has to be done from the age of 30 to 35. TP53 gene is associated with the Li-Fraumeni syndrome. It is a tumor suppressor gene located on chromosome 17. Li-Fraumeni syndrome consists of sarcomas which are diagnosed at less than 45 years of age. These patients will have a family history of first or second degree relative with a similar sarcoma at less than 45 years of age. Associated tumors are the soft tissue sarcomas, leukemia, breast, adrenocortical, and brain cancers. More than 45 years, patients can develop lung, prostate, colorectal cancers. Mean age of cancer in association with TP53 is 34 years, and 85% of the patients develop cancer before 60 years. Invasive ductal carcinoma and ductal carcinoma in situ are the common malignancies seen. It is HER2 or ER/PR, estrogen or progesterone positive tumors. There is a high risk of contralateral breast involvement. How do we screen? 20 to 29 years, annual breast MRI. 30 to 75 years, annual mammogram and MRI. Risk-reducing bilateral mastectomy is recommended. Lumpectomy is not preferred because the radiation that follows could further increase the risk of malignancy in the breast. Colonoscopy and endoscopy every 5 years, starting from 5 years before the age when the cancer first appeared in a relative. Annual dermatology consultation is also recommended. PTEN gene is associated with Cowden syndrome. This gene is located on chromosome 10. Cowden syndrome consists of mucocutaneous hematomas of the skin, breast, brain, thyroid, and GIT. It is autosomal dominant. Cowden syndrome is diagnosed based on major and minor criteria. Some of the major criteria includes hematomas, dysplastic cerebellar gangliocytoma, breast cancer, follicular or papillary thyroid cancer, endometrial cancer, macrocephaly. Minor criteria includes subcutaneous lesions like lipoma or fibroma, mental retardation, fibrocystic breast disease, genitourinary tumors. Breast cancer occurs around 30 years of age. Usually infiltrative ductal carcinoma or ductal carcinoma in situ is seen. Rarely, atypical ductal hyperplasia, lobular carcinoma in situ, fibroadenoma, fibrocystic changes, and nipple malformations may be seen. Screening would involve annual MRI and mammogram between the age of 30 to 35, thyroid screening with ultrasound, endometrial suction biopsy, and screening colonoscopy. CDH1 gene is located on chromosome 16, associated with hereditary diffuse gastric cancer. The average age for gastric cancer is 38 years. Breast cancer usually develops around 53 years. Invasive lobular carcinomas associated with this cancer. For these patients from 30 years, we need to do an annual MRI and mammography. STK11 gene is located on chromosome 19. It is associated with the Busch-Jaeger syndrome, which consists of mucocutaneous perioral pigmentation and GIT hamartomatous polyps. It is an autosomal dominant disease. The mean age of presentation is 37 years. Infiltrative ductal carcinoma is the most common. Men have an increased risk of Sertoli cell tumors, and they usually present with gynecomastia. Screening would involve annual MRI in ages between 25 to 29, 30 onwards, annual MRI and mammogram. ATM gene is associated with breast, pancreatic, and prostate cancer. Some cases also present with ataxia telangiectasia. Ductal carcinoma in situ is often seen. From 40 years onwards, annual mammography and MRI needs to be done. CHEK2 gene has a 25% risk of lifetime cancer. It is ER positive, associated with colorectal, stomach, prostate, kidney, thyroid cancers, and sarcomas. From 40 years onwards, we need to do an annual MRI and mammography. PALB2 is associated with BRCA2. There's a 33% risk of breast cancer, quite often associated with pancreatic malignancies, especially the solid pseudopapillary epithelial neoplasm. Some mutations can also cause Fanconi anemia. 30 years and above, an annual MRI and mammogram is recommended. Thank you.